I'll now invite Dr. Das for the final presentation. That is experience of eye care in a tribal district in Odisha.
The tribe we describe historically a social group existing before so-called civilization started in the state or a country or locality, etc. That is a description in a Webster English dictionary. There are supposedly distinct people. They are dependent on their land and their livelihood, oftentimes self-contained, sometimes self-sustained also, but unfortunately not integrated in a national society. But once upon a time, now aboriginals of Australia or tribes of India are slowly getting integrated in the mainstream. So oftentimes difficult to differentiate between a tribe and an actual person. By census of 2011, 9% or 10% of the Indian tribal population are Indians, live in India, and Orissa has got 8.14 million, which is incidentally 22.1% of the Orissa population in 2011 census. 4 districts of Orissa, which will show next slide, have got a population, tribal population more than 50%. These 4 are shown here. Name will not be easy to remember, so I will not talk about the name. So which is between 55 and 57%. We worked on one particular district. That district is called Rayagada, which is also predominantly one of those 4 tribal districts, though some industry here and there, but mostly are tribal. 2 particular, this Rayagada by geographical description is a population of almost a million people, 56% tribal. Is a 454th ranking in a district of India of 640 districts. Incidentally, the female ratio is more than male ratio, so the female literacy is though less than the male literacy. 2 predominant tribes of this particular district called Rayagada are called Dongriya. Kandha means a tribe in Oriya language, and other one is called the Soria. And they either stay in the hills and they are a little away from the community. Between the 2, this particular Soria is a little more closer to the civilization than otherwise. It's not difficult to reach, but then difficult to get anything done with them because they are reluctant to, they don't believe that you can do a good work for them. August 31, 2015, we established a hospital in this particular district, so-called Naxal infected district, and we insisted that Dr.Taraprasad must go there. And since then, we are working in that particular district. And when I did a third-party survey, how they are working after first 2 years, we found that good visual outcome, 90% of the people who had operated had a good vision outcome. Based on that, they have improved their daily skills or mobility or psychosocial improvement. Similarly, though Dr.Taraprasad by default doesn't do so-called screening or operation outside the campus, and then 80% of them came back for review because we are interested in improving the health-seeking behavior of people, and they are happy when they come to hospital as recommendation, food or waiting time, counseling, doctor's behavior, etc., etc. In this, this is not a updated data, but 2-year data shows that we had 35,000 patients examined, of which 53% were completely free. And we had roughly 3,700 surgeries, of which 86% were free. Predominantly in this kind of situation, will be 80% or 90% will be cataract surgery. We also had opportunity to, like Sandeep was talking about, opportunity to examine 153,000 plus children in their schools. Through the help of 215 trained teachers, followed by our own optometrist or doctors. This is one of those programs where optometry teaching those health workers and the teachers. Then also we had an opportunity to the help of the CBM examine people, door-to-door survey of 29 panchayats, of which 71% of the people staying on those people could be examined, not 100% because of either time you visit, they are not in the town, not in the home, or they are gone some other work, or children are in the school, etc., etc. But we would add the children of those areas, then become 75%, we know. experience, based on experience, with designs to write up what we are doing, and that program, that write up series we called TOAST, standing for Tribal Odisha Ideology Study. I will give only a brief overview of those 4 or 5 work that we have done. TOAST 1 looked at the prevalence and causes of visual impairment among the tribal children in urban location, because there is a school in Bhubaneswar where the tribal children from these 4 states and surrounding certain other states come and study. The only tribal student can study there. This actually school is named after tribal students only, and this is just getting in press in Japos. And this shows that the people of tribal students who live in an urban area today, 60% of them have refractive error, 17% have amblyopia, and 15% have posterior segment disease, but blindness prevalence was relatively low. Obviously, they will not recruit students who are blind to the school. I will not describe all the papers because it is not possible in a shorter time. This TOAST to look at the school screening program effectiveness of the multi-stage screening, because as Sandeep was talking about, we can't examine large number in one go. How to use the school teachers in vision screening, also examine detect the ocular anomalies other than the refractive errors, and that we found that we had these 4 stages. Stage 1 by the school teachers in the school, stage 2 photo refraction like Sandeep was talking about, done by the optometrist or the refractive person. Then comprehensive ophthalmic examination on those required to in a rural hospital in Rayagada, and then those are still further required in pediatric surgery, which you cannot do in Rayagada like place because of anesthesia problem to being to Bhubaneswar. So we found that teachers are 80% time sensitive and 53% specific. Unfortunately, negative predictive value are 26%. But we confirmed in this paper that detection of ocular anomaly beyond refractive error should be part of the school screening just for refractive error and giving pair of glasses. In TOAST 3, like Sandeep was talking about, we also performance of the SPART screener or the vision screener. We particularly use a well-trained machine, and we find and we do the photo screening of the people, required people, and those who are subjective correction only give the pair of glasses, but otherwise they get examined. We found that the photo screener utility in adults is poor regression analysis, poor regression, and then very good relations in children. We said that children only should use this particular device for screening purpose, and oftentimes can be used for in a particular range which your paper describes, can be actually prescribed glasses, but not without subjective correction. The TOAST 4 talks about the accuracy and utility of photo refraction actually in a school screening, but that was in a hospital-based situation, controlled environment. In school screening, this is submitted to IJO, and then this fellow says that there is a good correlation between good correlation between what you see and what you prescribe. So it is useful for the children to use, but these are all proven many times before, but we want to reprove it in our own setup. TOAST 5 talks about the comparison of prevalence and causes of visual impairment among tribal children in native location, like the Rayagada district example, or in an urban school like in Bhubaneswar, and this is in paper, still in preparation. It says that the urban people have worse visual impairment compared to the children sitting in the native area. But in a blindness severe impairment, there is none. Most of all is related to more reading or less ambient light reading, less amount of outdoor activities in a city like Bhubaneswar compared to the students in the villages. The final work panel paper is vitamin D deficiency. Government of Odisha has a constant denial there is no nutritional deficiency in particular district, though we thought there are, because we found out actually there are. And in this paper in preparation, it says that there are different forms of different stages of vitamin VAD, where their congenital genesis was highest 2.7%, followed by battered spot, corneal scar, and night blindness. And this is one example of we don't have example of a child we had in paper we had. There are few children who had a typical vitamin A deficiency with a sparse hair and thick skin and a lot of other things. So these are our effort in Rayagada study, but there are paper 7, paper 8 is not even thought, so we will not talk about that. Thank you very much for the opportunity.